Well, thank you very much for joining me and giving me an opportunity here at Link to talk a little bit about a disease that I'm really quite interested in and a technology that I'm quite impressed by. Here are my disclosures, and I am a consultant for InspireMD, so you need to consider that in your calculus. So when we think of carotid stenting, you have to recognize that while you can do the procedure with protection, the most important thing after the procedure is the stent itself. It's the final protection. And there are basically two categories of stents. You have closed cell stents where every tine is connected with every tine, versus an open cell design where some tines are not connected to others. And what does that mean? Well, closed tines tend to cover the plaque much better, but they're stiffer. They straighten the vessel out much more and don't cover tortuous vessels very well, whereas open cell designs have much larger holes for plaque to prolapse through, but they conform much better to tortuous vessels as carotids typically are. And so we have a variety of generation of these designs, open cell and closed cell. So wall stent is closed cell, Precise is open cell. And then there are now newer generation of devices which really are hybrid, where they combine the performance of closed cell and open cell into one particular form. So again, just to reiterate, open cell design like the one here on the left side is much more likely to conform to a vessel better, but has greater opportunity for plaque prolapse. Closed cell design don't conform very well. So that's where the CGuard stent, which is an open cell design on the inside and a very fine micronet mesh on the outside, combines both properties of a closed cell and an open cell design. Now, why is it important? Because there is data to suggest that the rate of stroke from procedures is lower with closed cell stents. So that plaque prolapse is really important. There's also data to suggest that the disability and DWI hits in these patients is also lower with closed cell stents. What's the value of these closed cell devices? Well, because 2/3 of strokes do not occur during the procedure. They occur after the procedure. Ipsilateral strokes, 2/3 of them occur after the procedure. So the only thing that protects those delayed strokes is this closed cell design that results in plaque protection. Now, there are a variety of different devices out there, but here's beautiful OCT imaging. So you can see on the left side, that's a very common finding with carotid disease. So personally, I use intravascular ultrasound in every carotid stenting case. And about once every 30 or 40 cases, I see plaque protrusion through the tines. And that is what is prevented when you have on the right panel the micronet machine. So again, it's the same concept here, resulting in multiple plaque prolapses, and those prolapses are much better protected with a FiberNet mesh because it covers the plaque much better. The other thing is, other technologies, including the dual layer design, such as the Casper stent or the Gore device, they have much larger holes than the CGuard, which is 50 micron holes that still allow patency of the external carotid, but much better plaque protection. Why is this sort of important? So we all know one of the Achilles heel of carotid stenting is DWI hits. We know they are lower with carotid endarterectomy and they are higher with carotid angioplasty and stenting. And so this is a study that was done, the Profi study was done with the MoMA device, which was protection. And what you can see is that MoMA device creates flow reversal and has been considered to be the best embolic protection technology for carotid thus far. And using this particular stent, you can actually reduce a half-fold reduction or half a reduction in the incidence of DWI hits and a 10-fold reduction in hits evident at 30 days. So this technology has been around for quite some time. Recently, the data was presented at the other LINC meeting, which is the vascular meeting in Leipzig. and by my dear friend Chris Metzger, and I'm going to share some of his results. This is a case from our Polish friend, Piotr Muselik, that demonstrates the value of how nicely it covers this almost near occlusion with a stent with beautiful IVUS imaging demonstrating no plaque prolapse. And this is the amount of data that's available commercially. So these are all studies done with the CGuard device, primarily outside the United States, 1,359 patients with cumulative 30-day death, stroke, and MI rate of 1.03%. So very good data. But you can always say this is not necessarily core lab adjudicated or multi-center. So here's the data from the CGuard trial, which was done in the United States and looked at both 30-day and 1-year results, looking at stroke, death, and MI. And when you look at these patients, almost 1/4 were symptomatic. So I think that's an important number to keep in mind because most carotid stent trials have asymptomatic disease. Post-procedure stenosis was only 7%, and post-dilation and pre-dilation results were quite excellent. It's important to note that they were all procedures done with embolic protection, both proximal and distal, or both, which is the way I do these things. And so when you look at the total stroke and death and MI rate was 0.63%. It's the lowest rate that has ever been reported for carotid angioplasty and stenting in any prospective, independently adjudicated trial that I know of, and I think I know all of them. So the 1-year results, again, demonstrate that there is some higher rate, so 1.95% at 1 year. So 30-day rate is 0.6%, 1-year rate is 1.95%, and I think you need to sort of keep that in mind in terms of per protocol and actual results. So when you look at the long history of carotid stenting trials, you can see that these are about as good as results get from carotid angioplasty and stenting, and really are quite comparable to endarterectomy. So finally, I believe we are getting to the point where carotid angioplasty and stenting and endarterectomy are quite reasonable. And so these results were very good. So moving on to a topic that's really important, and that's the central theme for me in the next 5 minutes, is tandem stroke. Tandem stroke is a common problem. All these major trials we know about, a third or a quarter of their patients had tandem strokes. And when you look at the outcomes, the best outcomes by far, by itself, is those that had tandem lesions. What does that mean? We benefit these patients more than any other LVO category. So it's a really important one to treat. Unfortunately, it's not very well associated with treatment. In fact, when you look at all these different trials, all of them demonstrate the value of intervening in carotids, but how we treat them is all over the place. So Mr. Clean, 30 patients underwent CAS, Revascat only 9, Hermes really no clear sort of outline of how to deal with the tandem stroke. But when you look at other data sources, it seems like this is a meta-analysis done, shows that the lower final Siddiqui score was much better in the tandem group that were treated, and outcomes were significantly better with the acute extracranial stenting group, and this is the German Stroke Registry, which is the largest set of data that is available. Now, stenting has been done for tandem strokes for a long time, and again, this is a very nice analysis done separating or dividing the two groups, and there's a massive benefit in favor of stenting acutely in these cases rather than just treating the intracranial lesion alone. So then the question comes, what do you do first? Do you go intracranial and suck the clot out and then stent on the way out, or do you stent first and then go intracranial? I don't think the jury is out on this one. I'm not sure what the best result is. I certainly know what my bias is. My bias is anterograde. Deal with the primary lesion. It's a symptomatic ruptured plaque. Protect it. Create your baseline. Go through it and then deal with the head. And usually in my practice, it takes 3 to 4 minutes to open a carotid. So we have looked at this, but we did not find any clear evidence of a direction. So in our group, we have people who do it both ways, and it's unclear. And even when we look at meta-analysis like this one done by Walid Brinjikci, it really suggests an improved profile in patients who were treated extracranial first. So I think there's a little bit of a bias with a lower result in these cases. The other thing I would say is proximal protection is paramount. So that's one of the most important things in cases. You can argue whether you need a balloon guide or not a balloon guide with the large guides like the 88 guides, which are going all the way intracranial. But for a cervical carotid, there is no question that no matter how big your guide is, you're not going to cover a 10 millimeter common carotid artery by itself. So it's important to consider balloon guides. Well, what we have done is we actually did a robotic study looking at transcranial Dopplers, and what we were able to demonstrate is that in 100% of cases, a balloon guide inflation in the common resulted flow reversal intracranially. So a very reliable, powerful thing that really protects you. So in the tandem occlusion, you don't have the luxury of putting a distal filter across the lesion because you don't know where the lesion is. So having a balloon guide really makes a big difference in these cases. And we looked at our own data on balloon guide use in tandem stroke. And this is 125 patients. Again, it's not independently adjudicated. But again, first pass effect, lower discharge NIH, better outcomes at 90 days, all in the balloon guide category. So I think that's something to keep in mind. And I'll sort of rapidly show you one quick case let's see, can we play this? Yes. So this is a patient left MCA stroke, and this is somebody, we always load them with aspirin Brilinta in the ER. There's a complete occlusion of the carotid. We identify the length of the lesion by using a long balloon, so we understand where the waist is. And then once that is done, then we are deploying a stent. This is under flow reversal. And once this is done, then the stent is up. Then we deflate our balloon guide and deliver it across the stent. So we don't have to worry about anything else. And now we are going to use aspiration. And this aspiration catheter is being tracked all the way up. And this is the final result of the case, and the patient actually did extremely well. So when you think of antithrombotic therapy, again, a lot of treatment options. People use 2B3A, aspirin, Plavix, all sorts of things are used. Again, it seems that antithrombotic use is better than not using it and then waiting for 24 hours. This fear of symptomatic intracranial hemorrhage appears to be misplaced in this particular setting. Now, it doesn't mean that it can't occur or it doesn't occur. It does, and I'll share those rates with you in just a second. So clearly, there was some evidence to suggest that extracranial treatment versus no treatment extracranially results in better outcomes in this randomized study looking at patients who underwent extracranial treatment first versus no treatment. So this is my rationale. I think it's better to be able to treat this very nicely with a stable background by doing the extracranial first. But there is a blind positioning of the stent. That's where I use the balloon to figure out where the waist is. This is another study that was done with the CGuard stent led by Purim Usalik. And in this instance, they had 50% tandem strokes. So half the patients in this category, 75, actually had tandem strokes. And when you looked at it, they used all kinds of mechanical thrombectomy, all kinds of locations. In most cases, they did just predilation. Again, just dilation and then stenting on the way out. In other cases, they did direct stenting. I'm in favor of direct stenting. And when you look at their results, overall, they appear to be quite good with symptomatic ICH rate of 5.3%. This is Francisca Dorn's data. This is a larger cohort looking at different kinds of subtypes of tandem athro, dissection, embolus. Here's a dissection case in which easy to pass 6 French Sophia through, and then you do a run and you get very good recanalization with aspiration, and just passing the Sophia through opens the carotid. So I think dissections sometimes do not require stenting. So you can be judicious in terms of exactly what you're using. But for atherosclerotic lesions, I think it's probably better to do stenting. Francisca believes the opposite. This is her data, and this is that she wants to do intracranial first because she's concerned about interaction between stent retriever and stent, and that's valid. But if with these new guides, we can easily cross almost always the stent. So she found in her data that there was thrombectomy first has slightly better outcomes. That's why I believe jury is out, and that's why I think we need some prospective data to really look at this with marginally improved outcomes in intracranial first. In terms of antiplatelets, here is the rate of symptomatic hemorrhage. You can see it varies between 5 and 10%, which is quite similar to all the data we have for Hermes, just LVOs. What Francisca does is she gives only IV aspirin and then starts ticagrelor after 24 hours. I think that increases the risk of acute stent thrombosis, and I believe aspirin, ticagrelor up front are quite okay. And she uses the dual layer device, the CGuard, primarily because there's concern that the metallic heavy devices such as Casper have a pretty high stent occlusion rate, 45% versus 3.7%. And so these are all studies that suggested using Casper for acute stroke, they have a very high rate of acute stent thrombosis. But when you switch to CGuard, this tends to be a lot lower. And the primary reason for this is metal surface area for Casper is almost 50%. So you do require the same kind of anticoagulation, antiplatelet therapy like a flow diverter. Whereas in the other device, your metal surface area is 5 or 6%. So I think the need for dual antiplatelet therapy rigor is a lot lower. I suspect Casper with dual antiplatelets would also perform better than what we have here. A lot of these patients were simply treated with aspirin alone. So I think this becomes really important. And again, the same thing is true for wall stent as well, with improved outcomes with Casper compared to wall stent. And I think these are all different stents that different centers that looked at in acute occlusion appears to be in 72%. So that's why I think using a dual layered low metal surface area device is a much better option than the others. So in the end, I think we do need more data, but stenting with anti-aggregation is beneficial. I think extracranial is better than intracranial first, but this is what she believed. And so I'm going to skip this to my last point here, which is, these are her cases, but since I disagree with that approach, I'm not going to share her data. But this is what I do. Okay, so CTA is done in all patients upon access, arch to vertex. And we do 4D CTA, which is a perfusion which is made into a dynamic CTA. If that shows me a terminus occlusion, then I don't stent those patients. But if it shows me a cervical occlusion, I load these patients with aspirin and ticagrelor in the emergency room, either by mouth or through NG. It's an 8 French femoral for me in almost all cases, unless they have a really complicated arch in which we can go radial. I use a balloon guide almost always, unless I can't use it because I'm doing radial. We cross the lesion with an 014, but I don't waste time. If I can't cross it with an 014, I will cross it with an 035. I'll use a 4 French, 5 French catheter, whatever, to get through the lesion, but with flow arrest. I use a long balloon to figure out where my lesion is. I do plasty, not with a 2 millimeter or 3 millimeter gingerly. I go with a 5.55 balloon right off the bat to really expand it, deploy the stent, deflate the balloon guide, advance it through the stent, and then do anything intracranially that I want, stent retriever, aspiration, or both. And I think that really is the way to consider it. So in my mind, tandem lesions are the most disabling category of LVOs, and they are the most aggressive version of carotid stenosis, symptomatic carotid stenosis. I think balloon guides are critical in the treatment of this disease. And I think post-stenting balloon guide can really be advanced beyond the stenosis and distal cervical ICA for any procedure. And I think CGuard is a unique way to protect from plaque prolapse during and after the procedure. And I thank you very much. Questions?
So do you change your protocol for patients for whom IV thrombolysis is indicated?
Not at all. Not at all. So the way I think about IV thrombolysis is that's our neurologist's job, whether they give it or they don't give it. It does not matter one iota what I do with the patient. I don't systemically heparinize my stroke patients, but I always give 2,500 for all endovascular procedures. That's all they have. I do load them with aspirin and ticagrelor when I think I might have to stent, and I stent first. But TPA does not come into equation. Yes, please. Hey, Ricardo.
Hey, Adnan. Looking forward to have this trial start in the US. Any difference between the position of the mesh on the Inspire, on the CGuard compared to the Casper?
Yes. So when you look at the point Ricardo is making is, it is really important to understand where the mesh is. So for example, there's another stent made by Gore called Scaffold, where the mesh is more on the inside as a PTFE thing. It makes the stent much more slithery, but the conformation is not any better, and it's more likely to have the membrane get ensnared with devices when you're going through or tear it. In this instance, the inside is the open cell design, the outside is the micronet mesh. So that ends up, you need the mesh to protect the plaque, so it's better to have it on the outside. And so the risk of injuring the micronet mesh is a lot lower. In fact, we have done a lot of work with Inspire to demonstrate that there really isn't any damage to the stent when you're inflating or deflating a balloon guide and going right through it for stroke. Okay. Right. All right. Okay, then I think that's it. Do you have a question? Okay, it's just waving, I guess. Okay, thank you very much.